You've probably been told these symptoms are nothing. Maybe stress. Maybe hormones. Maybe just life. You go to the doctor. Tests come back normal. And they send you home. But here's what nobody tells you. These symptoms, these strange, hard to explain things happening in your body, they may not be random at all. And once you connect them, everything changes. Today we are talking about 12 symptoms that women ignore, brush off, or get dismissed for, that could be pointing to Sjögren's syndrome or lupus. Two of the most underdiagnosed autoimmune conditions in the world. And by the end of this video, you're going to see a pattern that most doctors never show you. Stay with me. Because this one matters. Here's what usually happens. You notice something off. Something that's hard to explain. You bring it up. And it gets brushed off. It's probably just stress. Your blood work looks fine. A lot of women feel this way. And so you go home. You tell yourself it's nothing. But the feeling doesn't go away. And slowly, more symptoms start showing up. In different places. At different times. And you still don't have answers. That is the story of most women living with Sjögren's or lupus. The average diagnosis takes 3 to 7 years. For Sjögren specifically, it's closer to 10. 10 years of being dismissed. 10 years of silent damage. 10 years of being told you are fine while your immune system quietly destroys tissue you cannot get back. Before we get into the symptoms, you need to understand something. Most people think Sjögren's is just dry eyes and dry mouth. A minor inconvenience. That is not what Sjögren's is. Sjögren's is a systemic autoimmune disease that attacks nerves, blood vessels, the brain, the lungs, the kidneys, the gut, the skin, and the autonomic nervous system that controls every automatic function in your body. The dryness is just the surface. The real disease is happening underneath. And lupus works through a different but equally devastating mechanism. The immune system produces autoantibodies that circulate in the bloodstream and deposit in joints, kidneys, the brain, the skin, the lining around the heart and lungs. Everywhere they land, inflammation follows. Both conditions can cause damage for years before anyone puts a name to them. So let's go through these 12 symptoms. Not the surface version. The real version. What is actually happening inside your body when you feel these things? Number 1. Dry eyes that won't respond to eye drops. Your eyes feel like ground glass sitting behind your eyelids. Like something is in there that you cannot blink away. You reach for the eye drops. It helps for 30 seconds. Then the burning comes back. By midday your vision blurs. Light feels sharper than it should. You're told it's screen time. Allergies. Dry air. Here is what is actually happening. In Sjögren's, CD4 positive T cells and B cells infiltrate the lacrimal glands behind your upper eyelids and destroy the acina cells that produce tears. The cornea is the most densely innervated tissue in the human body. When it dries out, those nerve endings fire constantly. That is the burning. That is the grit. Eye drops replace volume but cannot replace the mucin and lipid layers healthy tears contain. Which is why they stop working within a minute. Year after year without treatment, the corneal surface begins to break down. Corneal erosions develop. In severe cases, corneal ulcers form. Open wounds on the surface of your eye risking infection and permanent scarring. Vision loss from untreated Sjögren's dry eye is real and preventable if caught early. Standard tests miss this because the Schummer test frequently comes back borderline and routine blood panels don't flag lacrimal gland destruction until significant damage is already done. In lupus, immune complex deposition in the conjunctival tissue adds a second layer of inflammation. Some women with lupus develop uveitis. Not surface dryness. Pressure behind the eye. A deep aching that feels like the eye is being squeezed from the inside. Type DIY eyes in the comments if you have been buying eye drops for years wondering why they never truly fix it. And if that first symptom already sounds familiar, you need to see how all 12 connect. I built a symptom map that lays out which symptoms belong to Sjögren's, which to lupus, which overlap, and what the full pattern means for your body, and also a map you need to track your symptoms. Type symptom map in the comments and I will send it to you. It is the kind of document that makes a doctor stop and take you seriously. Now let's keep going. Number 2. A mouth so dry it affects how you speak, eat, and swallow. Your tongue drags mid-sentence. Your lips stick together. You reach for water in the middle of a meal because swallowing without it feels impossible. At night you wake up with your mouth cracked on the inside. And then the dental destruction begins. Cavities on teeth you brush twice a day. Multiple crowns in a single year. Your dentist is confused. You are told to drink more water. Here is why that never works. In Sjögren's, the same immune infiltration destroying your lacrimal glands simultaneously attacks your parotid, submandibular, and sublingual salivary glands. Healthy saliva output is between 500 milliliters and 1.5 liters per day. In advanced Sjögren's it falls below 100 milliliters. Saliva contains immunoglobulin A that guards mucosal surfaces. Lysozyme and lactoferrin that kill bacteria. Bicarbonate that neutralizes acid on tooth enamel after every meal. When it disappears, the entire oral protective ecosystem collapses. Acid sits on teeth. Bacteria multiply without resistance. The dental damage from undiagnosed Sjögren's can cost tens of thousands of dollars to repair. Those teeth do not grow back. In lupus, shallow ulcers appear on the inner cheeks and hard palate. Not canker sores. These are caused by immune complex deposition in mucosal capillaries. They come and go with disease flares and are almost always dismissed as stress sores. Type DRY if the inside of your mouth has felt like a desert for longer than you can remember. Number 3. Exhaustion that sleep cannot fix. Not sleepy. Exhausted. There is a critical difference. Sleepy wants a nap. This kind of tired sits inside your bones. Your limbs feel weighted. Climbing one flight of stairs requires a recovery period. You cancel things you wanted to do because you genuinely do not have the energy to be upright for 2 hours. You're told it's thyroid, iron, depression. Nothing moves the needle. Here is what is happening at the cellular level. In both Sjögren's and lupus, the immune system exists in a state of chronic pathological activation that never switches off. In lupus, the body produces massive quantities of type 1 interferons constantly, even when there is no virus. They redirect metabolic resources away from normal cellular function toward an immune defense that will never end. Your mitochondria are directly suppressed by chronic inflammatory cytokines including interleukin-1, interleukin-6, and tumor necrosis factor alpha. These cytokines reduce mitochondrial efficiency and alter ATP production at the cellular level. Even after 10 hours of sleep, your cells wake up energy deficient. In Sjögren's, autoimmune inflammation damages the small nerve fibers of the autonomic nervous system. Standing up costs more energy. Temperature changes cost more energy. Digesting a meal costs more energy. Your body spends enormous background resources maintaining basic stability while simultaneously running a chronic immune response. No amount of sleep addresses that. Studies consistently show fatigue is the most debilitating symptom of Sjögren's. More impactful than the dryness. And yet it almost never appears on the diagnostic checklist. Type tired if you have tried to explain this exhaustion to someone and the word tired was never anywhere near enough. Number 4. Joint pain that moves and never makes sense. Your fingers won't fully close in the morning. Your wrists ache when you lift a cup. By afternoon your knees are stiff. By evening your shoulders ache as though you carried something all day when you carried nothing. Tomorrow it is completely different joints. X-rays come back normal. You're sent home. Here is what is actually happening. In lupus, immune complexes circulate in the bloodstream and deposit in the synovium. The thin membrane lining every joint that produces lubricating fluid. When immune complexes accumulate there, the synovium releases prostaglandins and matrix metalloproteinases that degrade cartilage. The inflammation migrates between joints because the immune complexes circulate and deposit wherever local conditions allow. That is not random movement. That is the same process occurring in different locations. And because lupus arthritis does not cause the bone destruction visible on X-ray in rheumatoid arthritis, imaging looks normal while the damage is active in the synovium and cartilage matrix. In Sjögren's, periarticular inflammation produces deep aching stiffness particularly in the hands and feet, that loosens slightly with movement but never fully resolves. Morning stiffness lasting more than 45 minutes is a clinical red flag for systemic autoimmune disease. Most patients living with this have never been told that. Type joints if your pain has never stayed in one place long enough for anyone to take it seriously. Number 5. Skin that overreacts to sunlight. A flush rises across your cheeks after even a few minutes outside. Sometimes a rash. Pink or red, spreading across your nose and both cheeks in a shape that mirrors the curve of your face. It looks like a blush but it does not fade. It burns slightly. You're told it's rosacea. Sensitive skin. Here is what is happening beneath the surface. In lupus, ultraviolet radiation causes keratinocytes to undergo programmed cell death. In healthy skin, the complement system clears that cellular debris quickly. In lupus, the complement system is dysfunctional due to autoantibody interference. The debris accumulates. The immune system detects it as danger and mounts a local inflammatory response. That produces the malar rash. The butterfly-shaped redness crossing the nose and cheeks while sparing the nasolabial folds. That sparing pattern is clinically specific to lupus. And UV exposure in lupus triggers systemic flares, not just skin reactions. Hours in the sun can activate inflammatory cascades affecting the kidneys, joints, and nervous system for days afterward. In Sjögren's, vasculitis of small blood vessels in the skin produces livedo reticularis, that lace-like purplish pattern on the skin from blood pooling in damaged vessels. And palpable purpura. Small raised red or purple spots from blood leaking out of inflamed capillaries. These are not bruises. These are visible evidence of blood vessel inflammation that keeps landing in dermatology as mystery rashes with no connection ever made. Type sun if your skin reacts to sunlight in ways that have never been satisfyingly explained. Number 6. Brain fog so severe it makes you doubt your own intelligence. The word you need is gone mid-sentence. Not on the tip of your tongue. Completely gone. You read a paragraph and absorbed nothing. You make errors in tasks you have done 1,000 times. You sit across from someone and realize you have not processed a word they said in the last 2 minutes. You're told it's stress. Perimenopause. Not enough sleep. Here is what is actually happening inside your brain. In lupus, anti-NMDA receptor antibodies and antiphospholipid antibodies cross the blood-brain barrier and bind directly to receptors in the hippocampus and prefrontal cortex. The hippocampus encodes new memories. The prefrontal cortex governs executive function, working memory, and attention. When autoantibodies bind to those receptors, they disrupt synaptic signaling at the receptor level. This is not metaphorical fog. This is autoimmune encephalopathy. In brain imaging studies, lupus patients show measurable structural differences in white matter compared to healthy controls. In Sjögren's, chronic elevation of interleukin-6 and tumor necrosis factor alpha directly suppresses dopamine signaling in the frontal cortex. Not mood dopamine. Processing speed dopamine. The kind that lets you hold multiple pieces of information in mind simultaneously. Autoimmune inflammation also damages the small blood vessels supplying the brain, reducing microvascular perfusion to regions responsible for memory and language. Neuropsychological testing in Sjögren's patients consistently shows deficits in processing speed and verbal fluency even when standard cognitive screening comes back normal. You pass the test while your brain is working twice as hard to do half as much. Type FOG if you have sat in a conversation and realized midway through that you were not processing what was being said and had no idea why. Number 7. Hair loss that no supplement ever fixes. Your part is getting wider. Your temples are thinner. You can feel the difference in the weight of your hair when you gather it in your hand. You try biotin. Different shampoos. Nothing stops it. In lupus, 2 distinct mechanisms drive hair loss with completely different implications. Diffuse non-scarring alopecia occurs when circulating inflammatory cytokines shorten the anagen growth phase, pushing hairs into the shedding phase prematurely. The follicle is not destroyed. This type can partially reverse during remission. But discoid lupus of the scalp causes immune complex deposition directly in the hair follicle, triggering fibrotic scarring that replaces the follicle permanently. The hair in that location will never grow back. And this process can be happening silently for months before a bald patch becomes visible because surrounding follicles temporarily compensate. By the time the patch appears, the follicular destruction beneath it has been accumulating for a long time. In Sjögren's, autonomic neuropathy reduces microvascular perfusion to the scalp. The tiny blood vessels supplying each follicle with oxygen and nutrients become poorly perfused. The follicle starves slowly. It looks like aging. It is immune-driven and vascular. Type hair if your hair loss has never responded to anything and you still don't have a real answer. Number 8. Swelling near your jaw or ears that comes and goes. A fullness below your ears. A tightness along your jawline. Sometimes one side, sometimes both. A dull ache or just pressure lasting days then subsiding. You're told it's a salivary stone. A dental infection. Here is what is actually happening. In Sjögren's, the parotid glands directly in front of and below each ear undergo lymphocytic sialadenitis. Lymphocytes flood the glandular tissue and form dense focal aggregates that physically expand and replace secretory cells. The gland enlarges. Not from infection. From immune cells crowding out the tissue that belongs there. And here is what almost no patient is ever told. Persistent parotid enlargement in Sjögren's is associated with elevated risk of MALT lymphoma. Mucosa-associated lymphoid tissue lymphoma. The lymphocytic infiltration that causes the swelling can undergo malignant transformation in a minority of cases. The absolute risk is low for most patients. But it is exactly why recurring unexplained parotid swelling should never be dismissed. A lip biopsy of the minor salivary glands in the inner lip is one of the definitive diagnostic tests for Sjögren's. A focus score of 1 focal lymphocytic aggregate per 4 square millimeters of glandular tissue confirms the diagnosis. Most people living with this jaw swelling have never been told any of this. Type glands if you have felt that fullness near your ears and been given an explanation that never quite fit. Number 9. Burning, tingling, and numbness that comes and goes and no test can find. A tingling in your fingertips when you are sitting still. Numbness in your feet that makes the floor feel slightly wrong when you walk. And at night, a burning on the soles of your feet specific enough to wake you. You see a neurologist. The EMG comes back normal. Here is why. In Sjögren's, the most common nerve damage is small fiber neuropathy. Small fiber nerves transmit temperature, pain, and autonomic signals. They are completely invisible to standard nerve conduction studies and EMG, which only measure large fiber function. The actual mechanism involves lymphocytic infiltration of the dorsal root ganglia. The clusters of sensory nerve cell bodies sitting just outside the spinal cord. When the immune system attacks those ganglia, a condition called ganglionopathy develops. Nerve cell bodies are damaged at their source. The burning appears in non-standard distributions. Hands, torso, face, a random patch on your thigh. Not the stocking and glove pattern doctors expect. Which is part of why it gets dismissed. In lupus, vasculitis of the vasa nervorum causes ischemic nerve damage. The tiny blood vessels supplying oxygen to peripheral nerve fibers become inflamed. The nerve fiber loses its blood supply and begins to die from the outside in. The burning quality of ischemic neuropathy is specific. Hot, constant, and reliably worse at night when circulation slows. Small fiber neuropathy that goes untreated can progress to large fiber involvement. Occasional burning becomes permanent numbness. Tingling becomes weakness. Discomfort becomes difficulty walking and gripping. That progression is not inevitable but becomes more likely the longer the autoimmune attack goes unaddressed. Type tingling if you have felt sensations in your body that no doctor could explain and no test could find. Number 10. Recurring low-grade fever with no cause. 99.5. Not high enough to call in sick. Not low enough to feel normal. Mildly achy. Slightly chilled in warm rooms. Like the beginning of a flu that never arrives. It passes. Then 2 weeks later it's back. For years. Here is what is happening. In lupus, elevated interleukin-1 beta and interleukin-6 act on the hypothalamus and shift its temperature set point upward. Your body generates heat in response. That is the fever. But because the driver is autoimmune rather than infectious, it is low-grade and cyclical. And C-reactive protein, the standard inflammatory marker ordered during a fever workup, is paradoxically normal or only mildly elevated in lupus because lupus primarily activates the type 1 interferon pathway rather than the classic interleukin-6-driven acute phase response. CRP comes back normal. The doctor concludes no significant inflammation. The patient goes home without answers. But erythrocyte sedimentation rate may be elevated. Anti-double-stranded DNA antibodies may be rising. Complement levels may be dropping. These are markers of active lupus flare activity. They are not the markers ordered during a standard fever workup. In Sjögren's, low-grade fevers occur during glandular flares and during episodes of extraglandular involvement when inflammation spreads to the lungs, kidneys, or peripheral nerves. The fever is the immune system's alarm. It is not fighting a pathogen. It is fighting your own tissue. Type fever if you have had recurring low-grade fevers for years that never led to any diagnosis. Number 11. Chest tightness and shortness of breath that keeps returning. A resistance at the bottom of a deep breath. Or a dull pressure in the center of your chest that appears without warning and fades an hour later. ECG normal. Cardiac enzymes normal. Chest X-ray clear. You're told it's anxiety. Acid reflux. Here is what is actually happening. In lupus, serositis is one of the official diagnostic criteria. Inflammation of the serous membranes. The pleura surrounding the lungs and the pericardium surrounding the heart. When immune complexes deposit in these membranes, complement activation triggers local inflammation. The two inflamed layers rub against each other and the organs they surround. The pain is sharp, worsens with deep breathing, worsens lying flat, and improves leaning forward. That positional pattern is nearly pathognomonic for pericarditis. But it requires a clinician specifically asking about position during chest pain. A standard ECG misses pericarditis unless the inflammation is circumferential and severe. A high-resolution CT and echocardiogram are the appropriate investigations. Without those, serositis is missed routinely. In Sjögren's, lymphocytic infiltration can spread to the lung tissue itself, causing interstitial lung disease. A progressively worsening shortness of breath on exertion that develops so gradually it gets attributed to being out of shape. Pulmonary function testing showing a restrictive pattern is the diagnostic indicator. Most patients are never tested because the shortness of breath seems too mild and the chest X-ray looked clear. By the time the breathlessness becomes undeniable, fibrosis may already be established. Type chest if you have had chest symptoms cleared on standard testing but never satisfyingly explained. Number 12. Feeling like your body is betraying you and no one believes it. You notice this not in a tissue or an organ. In the accumulated weight of your entire experience. The weight of leaving appointment after appointment without answers. Of describing symptoms clearly and watching polite skepticism spread across a doctor's face. Of having a test come back normal and feeling a strange guilt for still feeling unwell. Of canceling plans not because you don't want to be there but because you are physically not capable of it that day. Of smiling at work and sitting in your car in the parking lot afterward because you don't yet have the energy to drive home. Of wondering in your most private moments whether everyone is right. Whether you really are just anxious. Whether this really is just what getting older feels like and you are somehow failing to accept it. In autoimmune disease, the psychology is not separate from the biology. Chronic elevation of interleukin-6 and tumor necrosis factor, alpha directly dysregulates the hypothalamic pituitary adrenal axis. It alters serotonin and dopamine metabolism. The anxiety and depression that accompany years of undiagnosed Sjögren's and lupus have a direct neurobiological driver. The immune system is producing them. And then those symptoms are used as evidence that the problem is psychological rather than autoimmune. That is the cruelest part of this disease. It generates the very symptoms that are then used to dismiss it. Beyond the biology there is something that does not need a citation. The identity erosion that comes from years of not being believed. From learning to minimize your own experience before anyone else can minimize it for you. From pre-apologizing for bringing things up. That erosion is real. And it is one of the most devastating consequences of a delayed diagnosis. You were not imagining this. You were not exaggerating. You were not a difficult patient or an anxious woman who needed to stress less. You were sick. And the system kept examining individual pieces while missing the whole picture. Type dismissed if this is where you have been living. Because you are not alone in that waiting room. 12 symptoms. 1 pattern. Dryness. Fatigue. Joint pain. Photosensitivity. Brain fog. Hair loss. Glandular swelling. Nerve damage. Recurring fever. Chest inflammation. And the weight of not being believed. This is not random. This is not stress. This is your immune system attacking your own body across multiple systems simultaneously. The reason it takes years to diagnose is not because it is rare. Sjögren's affects an estimated 4 million Americans. The vast majority undiagnosed. Lupus affects over 1.5 million. Disproportionately women. Disproportionately dismissed. The reason it takes years is because each symptom lands in a different specialist's office. The burning feet go to neurology. The chest pain goes to cardiology. The rash goes to dermatology. The fatigue goes to primary care. Each specialist looks at their piece and finds nothing alarming within their specialty. Nobody looks at the whole patient. Look at the comments. You will see it. Fog. Dismissed. Tired. 10 years. 14 doctors. The same words. Over and over. Because this is not an individual experience. This is a systemic failure happening to millions of women simultaneously. Before your next appointment, here is exactly what to say. I want to rule out autoimmune causes including Sjögren syndrome and lupus. These symptoms have been happening together for years and I do not believe they are unrelated. I need an ANA panel, anti-SSA, and anti-SSB antibody testing, a complete complement panel including C3 and C4, and a referral to a rheumatologist. You are allowed to be that specific. You are allowed to walk in with a list. You are allowed to advocate for yourself without apology. Here is what I want you to understand about urgency. The damage does not announce itself. It accumulates silently. Cornea scarring. Salivary glands being destroyed. Small fiber nerves dying back. Lung tissue developing fibrosis. Kidney tubules becoming inflamed. All of it happening quietly while you are told your labs are normal. And Sjögren's carries a risk most undiagnosed patients never hear about. Sjögren's patients have a significantly elevated risk of developing non-Hodgkin lymphoma. Between 5 and 40 times higher than the general population. Most will never develop it. But diagnosed patients need monitoring for warning signs. Undiagnosed patients do not receive that monitoring. They do not know what to watch for. This is where people miss it. This is where early testing matters. I created a symptom map specifically for this. It connects all 12 symptoms, shows which belong to Sjögren's, which to lupus, which overlap, and what the full systemic pattern looks like on paper. The kind of document you bring to a rheumatology appointment to show that you understand your own body, and you are not leaving without answers. Type symptom map in the comments. It is free. And before you go, there are early warning signs that appear years before the symptoms we discussed today. Signs that show up in your blood work, in your sleep, in your nervous system, before any specialist would think to look for Sjögren's or lupus. If you know what they are, you have a window. That is what I will show you next. Make sure you are subscribed. Because that one matters even more than this one. You weren't imagining this. The burning in your feet. The fog that made you doubt your own mind. The exhaustion no one could see. The joint pain that moved and disappeared before anyone could look at it. The rashes that came and went. The years of sitting in waiting rooms and leaving without answers. All of it was real. All of it was connected. You were just never shown the full picture. You were given pieces. 14 different specialists handing you 14 different pieces of the same puzzle. And nobody ever laid them out on a table and showed you what they formed together. Now you see it. Take this. Use it. Share it with every woman in your life who has been told that nothing is wrong while everything in her body is telling her otherwise. Because somewhere right now there is a woman sitting in a waiting room. This is doctor number 14. Her labs are mostly normal. Her imaging is unremarkable. And she is starting to wonder if maybe everyone is right and she really is just stressed. She needs to see this. So share it with her.